Hi, Dr. Bhargava here. This is the next video in the series Body Imaging Case Review. Our first patient underwent a MRI of the abdomen with and without contrast, and the finding is incidental. They have multiple innumerable bilobar hepatic cysts that are small and all simple with no complex features. So on the contrast enhanced images on the top, we see that there is no enhancement. These are the largest cysts that are seen close to the dome of the diaphragm. And here on the coronal T2 weighted image, we find that both lobes are filled with T2 hyperintense foci, which are tiny, innumerable, and throughout the liver parenchyma. We see the same finding here on the transaxial T2 weighted image. And then in the bottom right, we have DWI and ADC images showing that there is no restricted diffusion. And so this finding is not very common, but we see it once in a while. It's developmental, and it's called biliary hamartomas, also known as von Myenberg complexes. Very important to remember that it is benign, and usually the patients are asymptomatic from it. Here's our next patient. They also underwent a MRI of the abdomen with and without contrast to further evaluate a mass arising in their left kidney. So on the contrast enhanced images, again on the top, we have non-con, arterial, portal venous, and delayed, and these are T1 and fat saturated images. We find that we have a mass arising from the left kidney and growing into the left renal vein. Here is the mass on T2 weighted image, slightly low signal, heterogeneous, also seen right here, and that extends into the renal vein. Renal cell carcinoma is one of the tumors that directly invades the adjacent renal vein and can grow up to the IVC and the right atrium and lead to tumor embolism as well. On the bottom right, we have DWI and ADC images showing restricted diffusion in this locally advanced renal cell carcinoma. Here is our next patient. They underwent laparoscopic cholecystectomy and presented with abdominal pain. Here is a representative image from their CT scan of the abdomen and pelvis, which shows cholecystectomy clips in the right upper quadrant, some free fluid that could be post-surgical, but no evidence of intrahepatic biliary ductal dilatation. So a HIDA scan was performed, and on the HIDA scan, we have acquired images in the anterior projection up to 1 hour, and these are every 5 minutes. So you can see 5, 10, 15, 20, and so forth. So at the end of 60 minutes, we find that the liver takes up the tracer. The uptake is good. There are no focal lesions in the liver, but there is no excretion from the liver into the biliary tract, into the gallbladder, or into the small bowel. And so this is called the liver scan sign of CBD obstruction. So what's causing CBD obstruction in a patient who has had recent cholecystectomy? So the next step for this patient's evaluation would be an MR of the abdomen along with MRCP. So these are the MRCP images. This 3D image shows the left and right sided bile ducts, the CBD, and we see the cystic duct remnant, but we don't see a part of the CBD where it extends to the ampulla. That part is absent. Although there isn't much proximal dilatation, but I would suspect that on some of the other images, there will be some abnormalities seen right here in this region, because we don't see the CBD completely extending to the duodenal ampulla. And that finding is seen right here. There is a filling defect in the most distal CBD close to the ampulla, and that is a tiny stone that is causing obstruction of the CBD. And so this was picked up on MRCP. MRCP as a modality is very good for evaluating bile ducts, CBD, and the ampulla along with the pancreatic duct. Here's our next patient, and I'm showing you single sagittal T2 weighted image from their MRI of the pelvis. This is a male patient, and we can see that the prostatic urethra is enlarged and abnormal. This is consistent with a TURP defect, or transurethral resection of the prostate, has been performed in the past. And also there is a T2 hyperintense focus between the prostate and the rectum, and this is a spacer that is used as a part of the IR procedure. So two findings here are TURP defect and the spacer, both seen as T2 hyperintense foci. Here's our next patient. There is a prior CT on the left where the finding is in the myocardium. So look at the heart. The left ventricular myocardium is thin and it almost appears aneurysmal, most likely from a prior myocardial infarction involving the LAD territory. So on the current or a follow-up CT of the abdomen and pelvis, the finding was incidental and it was picked up in the chest. So when we are reading CT of the abdomen and pelvis, a part of the chest is in the field of view, and sometimes there are significant findings that can be recognized and reported from that part. So here we find the myocardium looks similar as before, but attached to the myocardium there is this filling defect, and this is also seen right here. This is a thrombus. A thrombus is common in patients who have had prior MI, and as a result of which the left ventricle is dilated and aneurysmal, and recognition of this thrombus is very important because this can lead to emboli and lead to stroke in these patients. Here's our next patient, very interesting, presented with abdominal pain. The image on the left is a scout image showing dilated small bowel loops, and the image in the middle is the coronal CT image showing two large gallstones, some pneumobilia, dilated small bowel loops, distended stomach, so signs of small bowel obstruction. Here is another view of the gallstones. This one seems to be in the gallbladder, and the second one seems to be eroding through the gallbladder into the small bowel. Another image showing dilated small bowel loops. And at the bottom, we have an image, axial image of the pelvis showing some reactive free fluid in the pelvis. The other finding here is in the right lower quadrant. There is a stone which is similar to the other stones that I showed you before, and this is the obstructing stone. So in patients who have gallstones for a long time, history of prior episodes of cholecystitis, and they have chronic cholecystitis now because of stones being there for a long time, one or more stones can erode through the gallbladder wall into the small bowel, go through the small bowel and get stuck at the ileocecal junction, and that can cause that leads to bowel obstruction. Also in that process there is pneumobilia, and all of this is referred to as the Rigler's triad, also called gallstone ileus. The components of the triad are ectopic gallstone, small bowel obstruction, and pneumobilia. This is our next patient. They presented with fever, chills, and pain in the pelvis. It's a female patient. We performed a MRI of the pelvis with and without IV contrast, and with the suspicion of finding a urethral diverticulum. And so on the top, we have T2 weighted images, and these are in all three projections. We got axial, we got sagittal, and we have coronal images. There is a T2 hyperintense focus, which is surrounding the urethra. So that's the urethra right there, and here is the focus that is surrounding the urethra. It has thick walls. We have injected ultrasound gel for contrast into the vagina. We see that here. That's their uterus and cervix. Cervix has multiple Nabothian cysts. And here's the coronal image showing again that cystic lesion in the pelvis below the urinary bladder. On post-contrast images, we find that there is peripheral thick enhancement around that lesion, and on the DWI and ADC images we find that it shows restricted diffusion. So this patient has a urethral diverticulum. That diverticulum is infected because there is restricted diffusion inside and thick enhancing walls at the periphery. So classic findings for an infected urethral diverticulum. This is our next patient. There are two images from the CT scan on the left showing a complex mass arising from the right adrenal, also seen right here, sitting on top of the right kidney. And this was further evaluated using MRI. So we got two images which are T1 weighted images in and out of phase. On the out of phase images, there is signal drop from that image to here. And so when there is signal drop, that means that there is presence of microscopic fat, and that fat suggests that this adrenal lesion is likely a benign adenoma. So if it is a benign adenoma, it's unlikely to show restricted diffusion, and that's what we see right here in the middle. And adenomas show variable enhancement. Here we see that there is some peripheral enhancement and maybe there is some central enhancement as well, but it is overall a benign lesion. Also, remember that this may be FDG avid and may be confused with adrenal metastases in a cancer patient if you're doing a whole body FDG PET-CT scan. Also remember that by the time a cancer spreads to the adrenal, there would be other evidence of metastatic disease, which is hypermetabolic on the FDG PET-CT scan. So if there is a solitary focus in the adrenal, which is hypermetabolic, always consider that this could be an adenoma and ask for an MRI to further evaluate. This is our next patient, and the finding was incidental. We were performing their CT of the abdomen and pelvis, and here on the sagittal image you will find that this is the aorta, and we see the branching of celiac and SMA, but below that the entire aorta is occluded and almost atrophic right here. And so further down, more inferiorly on this axial image, we find that there are patent bilateral common iliac arteries, and they are patent because of collateral blood supply. And so it's not like when the aorta is occluded below the level of the SMA, there will be no flow distal to that. Collaterals develop over a period of time because this occlusion is not acute. It is secondary to atherosclerosis and thrombosis in patients with those risk factors for those pathologies and develops over a period of time. This often gives rise to what is called Leriche syndrome, and the clinical components of Leriche syndrome include erectile dysfunction, pelvis and thigh claudication, and absent or weak femoral pulses. So there is complete occlusion of the aorta, and distally the extremities, lower extremities are patent because of collaterals. This is our next patient. The finding was incidental, seen here in the enlarged liver. We have a part that shows enhancement, and there is almost like a geographic distinction from this posterior aspect of the liver that is fat infiltrated. And so this is called geographic infiltration of fat, and it's a benign finding, should not be confused with a tumor. This is our next patient. They presented with the history of passing bright red blood per rectum, and we performed a multiphasic CT using IV contrast to look for source of GI bleed. And so on the top, there are axial images from their multiphasic study. The first image at this level is from the non-contrast acquisition. Then we have the arterial phase, portal venous phase, and delayed phase. We see that in the arterial phase, there is contrast extravasation involving the transverse colon, and then that dissipates inside the lumen, and then there is more bleeding. And so because in that region we see extensive diverticuli, so this is probably a diverticular bleed occurring in the transverse colon. And so now you can call the interventional radiologist and tell them that they are bleeding from a diverticulum in the transverse colon, and you need to go catheterize and inject the superior mesenteric artery to find the bleeding and to occlude it. Here is a representative coronal image showing the same finding. This is our next patient, and the finding is again in the myocardium, seen incidentally on the CT of the chest. So this was a non-contrast enhanced study, and on this axial image we find these low attenuation linear focus involving the myocardium, also seen right here in the sagittal image, and this is scarring from prior myocardial infarction. This is our next patient, and the finding was in the left upper quadrant. Take a look at this focus. It's posterior to the spleen, and it's in the region of the adrenal. What could this be? It has a wall that shows enhancement, and if you are paying attention, there is a focus of air or gas right there. And so that focus is not some kind of a cyst arising from the adrenal or a lesion, but a gastric diverticulum. Here is our next patient. They presented with left lower quadrant abdominal pain and diverticulitis was suspected. CT was performed of the abdomen and pelvis with IV contrast, and we see findings that do not represent diverticulitis, but there is fat stranding in a ring-shaped fashion with a central dot sign. And that central dot in other projections can also look like a line, which is a thrombosed vein. It could be this one as well. And so this whole focus of fat stranding is adjacent to or is abutting a wall of the colon. And it is a epiploic appendage that has undergone inflammation, and this finding is called epiploic appendagitis. Next patient here on their CT of the abdomen and pelvis, there was an incidental finding. You can see that there is fat attenuation in the chest behind the liver, and on the coronal image we find that there is a defect in the diaphragm and there is fat going from the abdomen into the chest, and it's also seen right here. And this finding is called diaphragmatic hernia. It's in the back or the posterior aspect of the diaphragm, and the name for that is Bogdalic hernia. This is our next patient. They were diagnosed with cervical cancer and a FDG PET-CT was performed, and we find that that's the large tumor that's hypermetabolic. They have right pelvic lymph node that shows metastatic disease, and on this whole body image there is no other evidence of metastatic disease outside of that focus in the right side of the pelvis. On the bottom left we also have a axial T2 weighted small field of view image from their MR of the pelvis showing the tumor in the cervix, bilateral parametrial extension, and these two T2 hyperintense foci. These two T2 hyperintense foci look like this on the sagittal image, and at another level in the sagittal image we find the extent of the cervical tumor. And so these structures are linear, they look like ureters, and if we pay attention to the appearance of the left kidney, we find that it's taking up the tracer and it's trying to excrete it. The right kidney, not as much because the function is compromised. And the function of the right kidney is compromised because there is hydronephrosis, and the hydronephrosis is because the distal ureter close to the UVJ is affected by or infiltrated by the cervical tumor. And that is a very common thing when young females present with hydronephrosis, unilateral or bilateral. The most common reason is a advanced or a locally advanced cervical tumor. And so this patient has duplicated ureter on the right side, and that ureter is being occluded by the tumor, because of which there is hydroureter, and we see signs of hydronephrosis on the FDG PET scan as well. Here is our next patient. They presented for an MRI of the abdomen because of an indeterminate mass in the right lobe of the liver. So the T2 weighted image, we find this ill-defined, large, heterogeneous T2 hyperintense mass involving segment 6 of the liver. Here is the coronal image showing that same T2 hyperintense heterogeneous mass. On the contrast enhanced images, we find that there is contiguous or continuous peripheral enhancement and central fill-in, which we also see right here. And so when the enhancement and fill-in are continuous from outside to inside, the pathology is likely to be cholangiocarcinoma. Here is the DWI image showing restricted diffusion and a very high signal. And so the biopsy proved that this was a cholangiocarcinoma. They're generally heterogeneously T2 hyperintense, may show central necrosis, as opposed to hepatocellular carcinoma that shows arterial phase uniform enhancement. They show peripheral enhancement, and on delayed images there is fill-in similar to hemangiomas, but hemangiomas are generally more well-defined and more T2 hyperintense and will not show restricted diffusion as compared to cholangiocarcinomas. All right, another interesting patient with chest pain radiating to the back And at that time, they did not want to give contrast to the patient because of risk to the renal function. But their suspicion for an aortic dissection was very high. And on this single image, I'm showing you a small to moderate size hiatal hernia. And look at the aorta. There is a slight hyperdensity seen right there. And so this was called on this non-contrast enhanced, and we asked them to do a contrast enhanced CT, because doing a contrast enhanced CT to diagnose this aortic dissection has more benefit to the patient compared to the risk of damaging their renal function from the contrast administration. So a contrast enhanced study was performed and a aortic dissection was correctly reported. The smaller lumen is the true lumen that is showing is brighter, and we see that that lumen supplies the left renal artery, that shows better perfusion. The false lumen is right here and also right here, which is perfusing the right renal artery, which shows less enhancement compared to the left side. Here is our next patient, and they came with a history of vaginal melanoma, and a FDG PET CT was performed for whole body staging. We find that the tumor is hypermetabolic. It is seen right here and also right here on the axial images. There are hypermetabolic metastatic nodes in bilateral inguinal region, and perhaps also higher up in the pelvis as seen on this MIP image. The patient also had an MRI of the pelvis. On the MRI, here is the lobular T2 hyperintense mass, also seen right here, and here on the coronal T2 weighted images. These are all T2 weighted images on the top. And then on the bottom left, we have a T1 image. Remember that melanomas are intrinsically T1 bright, and that's what we see here. There is T1 brightness in the tumor, and on the post-contrast images, there is enhancement, and also we find that the tumor shows restricted diffusion. So multiple findings on different studies in a patient with a rare tumor, a metastatic vaginal melanoma. This is our next patient. FDG PET CT whole body scan was performed, and there is no focal hypermetabolism to suggest active neoplastic disease. There is an incidental finding of linear focus of mild to moderately intense uptake seen in the chest, and that focus in the chest is seen right here. It corresponds to the tip of a central venous catheter. The catheter is also visualized right here. And so frequently at the tips of the catheter, there is focal FDG uptake, and that can be secondary to either a developing thrombus or an infection. Thank you for watching.